Hello everyone, and today I'm going to be talking to you a little bit about adapted technique in radiography. And this is one of the most highly requested presentations that I've been asked to do, but mainly focusing on how we correct our images and what to do if you need to repeat. So I'm going to be going through that today with you, the sort of basic principles behind it, and also some examples so that hopefully can help you understand it a bit better when we look at things in practice. Now, typically when we think about adaptive techniques, we think about being in A&E, we think about trauma patients, people with fractures or complex injuries, multiple injuries, and they can't move the body part that we want them to as they normally would. So we have to work around them and adapt as many things as possible. But we also encounter adapted techniques in other areas like GP and outpatients. So it's not just people with complex fractures or injuries, it can be anybody, and we need to be able to prepare for that when we go out into practice. But adaptive techniques also includes adapting your exposure factors, which is something that not a lot of people realise. So when we take our exposure factors down for a small child or a baby, and when we increase them significantly for a patient who is quite large. And we do these because, first of all, we want our patients to be comfortable and cooperate, and we want to make the process as easy for them and as painless as possible. Because if they've already got an injury or multiple injuries that they're dealing with, multiple conditions, we don't want to exacerbate them any further or cause them any more pain. But we also do this because of the principle of ALARP or ALARA, so as low as reasonably practicable or achievable. And if we do these adaptive techniques in the first place, then it minimises the chance of needing to repeat our images, which again adds to the cumulative dose, which isn't very good. We want to keep that as minimal as possible. Some examples of how we adapt our technique. As you all know, angling the tube, when you would normally get the patient to move themselves when they can't move the body part that we need them to, because we need to keep that perpendicular relationship to the image receptor. We can also take x-rays with a different central ray. So for example, if you're doing a lumbar spine x-ray, typically if you've got a GP patient, you would ask them for the lateral view to roll over either onto their left or their right side, and then you would keep the vertical central ray centered over the table bucky, and you would do it that way. But if you've got a patient from A&E and they're on a trolley with a query lumbar spine fracture, you are not going to move them at all. You're going to keep them as they are, and you're going to centre using the horizontal central ray against the wall bucky, because we don't want to injure them any further and making their injuries worse by moving them. And also adaptive techniques include using positioning aids, so things like sponges, blocks, leg holders, sandbags, cassette holders, all of these things so that we can help get get our area of interest on the image first of all, but also to help the patient help us as much as they can to support them and their affected body part. So an example of this would be if you have a patient with diabetes and they have a diabetic foot, what can sometimes happen with that is they lose feeling in their foot and ankle, so it goes completely numb. And if you're trying to do a foot x-ray on them to see if they have any osteomyelitis, they may not be able to bend their knee and keep their foot in the same place because they can't feel it, and that's not their fault. So we need to help them, and what we could do is pop a angled sponge underneath the image receptor, one underneath the ankle as well, so we raise the affected body part and we keep it in the same place so that we get the entire area of interest. Now, the next part I want to talk about is one of the most important things, and these are the basic ideas about how we identify and then describe the angles that we're going to apply. So first of all, if we can't move our patient, the anatomy that is furthest away from the image receptor will move or will be projected the most with the angle that's applied. Now, if we can move our patient, we need to think of our patients or their body parts sort of as on an axis. So one half moves one way, one half moves the other way. Anatomy in the upper half of the patient will shift with the rotation. So for example, move in the same direction. Anatomy in the lower half of the patient will shift against the rotation, so it will move away from the centre of rotation. So if I give you an example, say we're doing a lateral wrist, we've got the radius and the ulnar. One of them is going to move one way, one of them is going to move the other way, if you think about the wrist as being on an axis. The final key point is to remember the anatomical position and why we use it. And when I come on to the examples in a second, I'll show you why this is important and how it can sometimes confuse us and trick us out a little bit. So, first example, we have a picture of a horizontal beam left ankle here. And as you can see, the distal end of the tibia and fibula aren't quite superimposed. We haven't got that nice clear joint space that we're expecting. So let's go through it step by step. What's furthest away from the image receptor? Well, if we've got the image receptor on the medial side of the leg, then the fibula is going to be what's furthest away from the image receptor. Now, looking at the image, the fibula needs to move anteriorly. It needs to come up to be more superimposed in layman's terms. Therefore, we need to apply an anterior angle. Now, back to what I was saying about the anatomical position, you may want to describe that as a superior angle because we're moving the tube up, we're angling the tube up, but that's not right, because if we think about the anatomical position, that is actually anterior if you're stood up in that position. And now exam tip, always state the angle in degrees and the direction, and you can't state a range, you have to state an exact number. So for small anatomy, anywhere between 3 and 10 degrees is usually acceptable. Usually around 5 degrees for most small anatomy. It's not too far looking at the image, is it? Now, next example, the knee. Everybody's favourite. I'm one of these people who either gets it absolutely spot on or completely wrong. There's no in between. But don't panic, we've got this. Let's look at the image. So again, we've got a horizontal beam left knee. And as you can see, the femoral condyles aren't superimposed and the fibula head is hidden quite away behind the tibia. Now again, if we've got the image receptor on the medial side of the leg, the fibula is again furthest away from the image receptor. Now, opposite to the ankle that we just did, the fibula needs to move posteriorly, it needs to move down to bring the fibula head into view because we need to see a bit more of that, and that will then superimpose the femoral condyles, hopefully. So we need to apply a posterior angle, not an inferior angle if you're describing it in your exam, and again approximately 5 degrees, 5 to 7 degrees, something like that. Just make sure you state an exact one. The knee again, but this time we've kind of gone too far the other way, haven't we? We can see too much of the fibula head, we can see the joint space, the tibio-fibular joint space, and again, the femoral condyles aren't quite superimposed. So, medial side is where the image receptor is, and the fibula is furthest away. Now, the fibula needs to move anteriorly, it needs to move up so that we can superimpose the femoral condyles, and then we can apply an anterior angle. Again, approximately 5 degrees. And in the corner, I forgot to point this out earlier, but I've included a picture of, your perfect, your gold standard horizontal beam knee, just to see whereabouts we should be to compare the image that we've got. So that's it. It's quite short and sweet. Um, I hope you liked it and I hope you found it useful. Do DM me either on Instagram or Twitter if you've got any suggestions of things that you'd like me to cover. I did mention before that I will be doing an exposure factors PowerPoint, so you don't need to worry about that. I've already got that sort of in the works. But if you have any other suggestions of things that you'd like me to do to go over, then yeah, you can get in contact with me. Thank you for listening.